I want you guys to imagine this. You're rushed into the ER, struggling to breathe. The doctor leans over you, asking rapid questions, but you don't understand a single word. You try to explain yourself, but no one understands you either. This is the reality for what happened a few years ago. A Spanish-speaking patient sadly passed away due to a misunderstanding of the word intoxicado while in the ER. And this is the reality for more than just one, but for millions of Spanish-speaking patients in the US every single year. And way too often, the difference between life and death depends on whether a qualified interpreter is available. My name is Ronak Aggarwal. I'm a student at Greater Atlanta Christian School in Duluth, Georgia, and I worked on this project with my mentor, Ms. Brianna Cevallos. I chose this topic because I believe language access should never, ever be the barrier that prevents someone from receiving safe and high-quality care. This project stemmed from last summer when I was shadowing in a major health system nearby. I shadowed 5 doctors total, and all 5 had the same issue. They had a hard time obtaining an interpreter. Back then, I didn't know it, but that observation would plant the seeds for a 9-month research project. Today, I'll be presenting my project, Spanish to English Medical Interpretation, Systemic Barriers to Equitable Care. My thesis for this project was, despite federal protections, Spanish-speaking patients continue to face barriers to equitable care because hospitals often prioritize cheaper remote interpretation over in-person services. This over-reliance undermines accuracy, cultural competency, and patient trust, underscoring the need for systemic investments in high-quality and accessible interpreter programs. And in the US, over 25 million people are considered to be limited English proficient, and 2/3 of them are Spanish speakers. And despite federal laws, hospitals rely on cheaper virtual methods, and you will see throughout this presentation on why that is. My central question for this project was, how do systemic and institutional factors influence the accessibility and effectiveness of Spanish to English interpretation services in US hospitals? I was not just asking if interpreters were available and when, but why barriers persist. I examined the accessibility and effectiveness and how hospital systems themselves can create barriers or help reinforce them. To answer this question, I used a mixed methods approach. I reviewed existing literature and policies, surveyed over 20 interpreters and 5 providers, and conducted interviews with 4 hospital administrators from 4 different large health systems in Georgia. This combination gave me both national context and local, on-the-ground experiences. I had numbers to measure the issue and voices to explain it. My first key finding from this problem is about interpretation quality. In my survey, interpreters rated in-person interpretation as the gold standard, a whopping 9.26 out of 10 for effectiveness, compared to just 8.42 for video and 7.0 for phone. Even though the rankings for effectiveness are in this order, unfortunately, the usage rankings are the exact opposite. Phone, then video, then in-person, and dead last. This isn't just my data. National research backs this up too. Locatis et al. Found that in-person interpretation is significantly more accurate and fosters greater patient trust than virtual methods do. So while hospitals lean heavily on cheaper phone or video interpretation, both providers and patients consistently say nothing replaces being face-to-face. One provider put it in simple terms: phone calls cannot capture body language. Patients feel isolated. My second key finding was about staffing and workflow. 80% of interpreters reported shortages. They rated their integration in the care teams a sad 2.95 out of 5. Providers described delays when waiting for in-person or phone interpreters in emergencies. And in my interviews, 75% of administrators admitted that cost was the main reason interpreters were not included in urgent care. As one interpreter explained, sometimes I'm asked to stay longer than expected to meet unexpected need or help with a high volume of requests. Just the fact that this problem is unexpected is truly shocking. Language access is a measurable issue, and hospitals need to track it. In fact, when requesting the ethnicity breakdown for readmissions from one health system in Georgia, I was reported to be the first person ever in the whole history of the hospital to ever request that kind of information, meaning that the health system has never tracked that in the past. This cycle of understaffing, burnout, and exclusion puts many patients at risk. My third finding was cultural competency gaps. Providers often lack training on how to work with interpreters, and over half of interpreters admitted to making mistakes that directly affected patient care. Misunderstandings were common, averaging a sad 3.63 out of 5. One interpreter told me, "We aren't included in treatment discussions. Patients feel left out of their own care." This lack of training undermines patient trust and engagement, making interpretation less effective even when it's available. Taken together, these findings reveal a troubling national pattern. Hospitals prioritize cost and efficiency over communication quality. In-person interpretation is the gold standard, but shortages force reliance on virtual methods. Staffing is framed as unexpected, which fuels burnout and underinvestment. Cultural competency is weak, leaving providers unprepared and patients feeling ignored. And while there are laws that guarantee language access, like Title VI and the ACA, hospitals do not enforce it, and they face almost no consequences for noncompliance. As one interpreter put it, language access is merely treated like a checkbox until accountability improves. My research points to 4 main recommendations. First, enforce language access laws with real accountability. Without consequences, hospitals will continue to treat interpretation as an optional assignment that many people don't do. Second, hire and retain more qualified interpreters. Spanish interpreters are measurable. This problem is not unexpected, it's measurable, and hospitals should plan for it. Third, integrate interpreters into both urgent and routine workflows. They should never, ever be excluded from emergencies, and that's when communication is most critical. Hiring more interpreters in emergencies will help prevent the cases, like I mentioned in the first slide, where a patient died due to miscommunication. Finally, provide cultural competency training for providers. This would improve collaboration with interpreters and build patient trust. But these aren't just best practices, they're essential practices. They're essential for safe and equitable care. To conclude, there are 3 main takeaways. First, over 25 million people in the US are limited English proficient, and most of them are Spanish speakers, 67% to be exact. Despite their numbers, hospitals are still failing to provide consistent interpretation. Second, interpretation was rated at a 9.26 out of 10 when in person for effectiveness, compared to just 7.0 for phone. Yet hospitals continue to rely on the least effective option only because it is cheaper. And finally, in my interviews, 75% of administrators admitted cost was the main reason that interpreters were excluded from emergencies. This means patients face the greatest risk that they will ever face due to a lack of staffing. Together, these findings show that interpretation is not just optional. It is essential to safe, equitable, and high-quality care. No patient should ever feel unsafe or unheard simply because they don't speak English. Thank you so much.
Wow, that was awesome. Can you guys see me? Can you hear me, Ronak?
Yes.
Okay,
Yes.
good. No, that was wonderful. Thank you so much for sharing. We have a couple questions for you from the audience. The first one is, what was the hardest part of your research process?
Well, the hardest part was obtaining the opportunity to interview interpreters and providers and speak with language service directors from 4 health systems, because they treated me as merely a high school student, not as someone who wants to change the field of medicine.
Wow. And that goes right into our next one, because they said, what are the next steps for you now that you've completed your project? Will you continue to build upon this?
Oh, sure. Yeah, definitely. So right now I'm actually embarking on my next project which builds off this one, exploring language access in rural areas. So my goal is by the end of my high school years to have done 3 projects over this topic to be able to create a program to help increase staffing and workflows in different health systems.
Wow, that is that's awesome. That's incredible work. Well, thank you so much,
Thank
Ron.
you.
This was fantastic. Thank you so much.